Nebulizers are the primary mechanism, in the hospital at least, as far as how we administer medication. Really? And their categories include small volume, large volume, and ultrasonic. It's got a mind of its own. It didn't even touch anything that's moving. Difference between nebulizer and an atomizer. An atomizer is what your perfume is or cologne is in. You press the button, you get this mist, but it's larger particles. Whenever you place something called a baffle, something in the way of that stream of aerosol, it takes the larger particles out of suspension. Okay, so it can be, in this case, it's got a little ball that's there. It can be a wall. It can be something that basically traps those larger particles, causes them to fall back into solution. Okay, an atomizer doesn't have a baffle. A nebulizer does. And we know about Bernoulli principles. This is how it works. I put a flow of gas by a restriction. With that restriction, the lateral wall pressure decreases. It creates a vacuum, sucks that fluid up because there's a subatmospheric pressure at that point. Okay, it says capillary action basically is the way that they end up using. And it's all based on Bernoulli's principle, which nobody remembers because that was just some silly guy from last semester that we already got out of our mind. Typical jet nebulizer you end up having working under that principle. Notice here I have a baffling mechanism, something that's going to take those particles that are created and make them into a smaller the larger particles will fall out back into the medication reservoir, the smaller ones then continue onward. Technically, it can be a mainstream versus a side stream. For our purposes, we're not going to worry that much about the distinction between the two. Just recognize the flow. It can be basically placed into the flow of gas, or the flow of gas can be passing through it. There's two different approaches to it. Some other ways that this is the traditional way that we have when we deliver most medications. It's a constant output. So the green line there shows the output that the nebulizer is generating, where you can see that it's continuing regardless of how the patient's breathing. So during the expiratory phase, it's still nebulizing, which in a way is wasteful. Okay. There are what are called breath-enhanced nebulizers, where the output is increased during the inspiratory phase. It senses the patient taking a breath, and it goes ahead and increases nebulizing during that inspiratory phase, and then goes back down to a lower level during the expiratory. These are called breath-enhanced. And one of the ones we'll end up seeing is something called the Peri-LC nebulizer, is one of those examples. And there's certain medications that are recommended to be used with this nebulizer. And this is an example of the Peri nebulizer. You can see it can even be used on a small infant with a mask attached to it. There's also what are called dosimetric, where again it's breath activated, but it only works during the inspiratory phase. When it senses the patient no longer drawing flow, it shuts itself off. Okay. This allows for a very, very precise amount of medication to be delivered. And a couple of examples, and I'm not going to test you on names. I don't care that you necessarily know the name, but recognize that these are some specialty nebulizers. The AeroEclipse, which again senses a patient effort and nebulizes during. Is it the busiest slide you've ever seen? It's like, what the hell is it saying? It's saying that it only delivers medication during the inspiratory phase, shuts itself off during the expiratory phase. Most of the time, we're just going to use our traditional small volume nebulizer. The range is within the desired range. Ideally, you want 2 to 5. Some particles can be a little bit smaller, some can be a little bit larger. And they vary tremendously brand to brand. And this is one of the, I worked in a hospital where they were very cheap, and they bought the cheapest thing they could find, and you threw away half the nebulizers because they didn't work. So what do you gain in the long They're usually powered by some kind of pressurized gas. Usually we just use wall oxygen. If you have a patient who is sensitive to high quantities of oxygen, you can use compressed air. And they typically have somewhere between 10 and 20% deposition inside the lungs. So that means that 80 to 90% goes someplace else, onto the patient's face, the back of their throat, to the atmosphere. And there's a lot of things that affect output of a specific nebulizer, and some of them are how much you put into it. And really, when you use these devices, you'll end up having a point in time where it actually starts to sputter. It doesn't have a smooth nebulation you can audibly hear, and patients will insist that if they just wrap on a little cup, I'm going to get more out of it. Well, no. There's a study that was done that once you get down to a specific volume, the output goes down whether you smack it on the side or not. It doesn't really make a difference. There's some other factors that are involved. The drug itself is really going to be a huge factor. Some nebulizers do not function well when the medication is very viscous, as we'll find acetylcysteine is a very viscous, thick, gooey medication. Some nebulizers don't handle it well. So it has a lot of factors involved. I'm not going to expect you to memorize the list. They're pretty much common sense things in the long review. We know about air versus O2. We know about continuous versus intermittent. When we apply it to the patient, there's different ways we can end up applying it. We can use a mask. We can use a mouthpiece. Okay, so the patient would basically be having the mouthpiece in their mouth, and there's usually an extension tubing on the opposite side of a T adapter, so that as they breathe in, they get the medication. When they exhale back out, it goes out a different port. We can apply supplemental oxygen. They can be wearing a nasal cannula, for instance, during the therapy. It's not going to cause any kind of problems. If the patient has an artificial airway in, we can adapt it to that artificial airway in some fashion. Advantages of an SVN is that it can be used in pretty much any age population. There's no coordination required like there is with a meter dose inhaler. They can have slow inspiratory flows, low inspiratory volumes. It's not optimal, but it still can be done. Does not require a breath hold for efficacy. Let me make a point about that. Okay. Do I have to have a breath hold? No. So a patient who's comatose, it's a perfectly acceptable, in fact, that's probably your only option to be able to use. They can't do a DPI or an MDI. They're not having any function cognition. Is it optimal? No. Now, if you read Egan has this one comment in there about how breath holds are not needed with a small volume nebulizer. That's correct. If you take a look at the study that is referenced by Jim Fink, who is a good guy and I know well, the study was done on 16 people. Common sense tells you that a breath hold is going to improve deposition. Just because 16 people didn't show statistically significant, well, 16 people, you're not going to get statistical significance anyway. So you don't have to have it, but for efficacy, you really should have a breath hold. Ideally, when a nebulizer therapy is being administered, we want them to take a slow breath in to maximal, as deep of a breath as they can, hold that breath for a few seconds, then exhale back out again. Okay. And the good thing about an SVN is I can change the dosage of the medication, so it's not fixed like it is with a DPR and MDI. I can go ahead and I can make it a different dosage if necessary. Levalbuterol, if you remember, comes in 3 different concentrations for 2 different population groups. Disadvantages, well, it's cost of the nebulizer. Treatment times typically are 10 minutes, 12 minutes in duration for the normal 3 milliliters of solution to be nebulized. Where we're going to talk about an MDI, you can be in and out of the room in a minute and a half. This takes a little bit more. There's always a potential for contamination. In between treatments, it's recommended that that sterile water is rinsed out the nebulizer cup. I've seen people not use that, and that just allows then that medication that's sitting in there left over to be potentially contaminated. You need an external power source, either compressed gas or electricity. So this means that portability of these are not as good as, say, an MDI or DPI. Because if I got to have power, well, that means that I have to have an adapter for my car or some mechanism for that to be able to be used. So again, this is the conventional nebulizer, the way we would end up doing it. Put the drug in a nebulizer, set it to a flow of typically 6 to 8 liters per minute. It allows for treatment duration of somewhere around 8 to 10 minutes. You want them to breathe slowly through their mouth and with a breath hold. And when it begins to sputter, we're end up done. We're going to rinse it with sterile water and air dry it, or throw it away, which is not going to typically be done. Treatments are done multiple times during the day. And then go ahead and assess their outcome and adverse reactions. In the home, it's recommended that they are washed with a mild soap and warm water and rinsed. You can also soak them in a distilled vinegar in water, distilled water, and then rinse with sterile or distilled water after it's done. And a lot of times patients in the home, that's a whole separate world as far as going in and some of the stuff you end up seeing. We're not going to worry about mechanical ventilation. I think it's what we covered about it. So we'll be covered that in the fall. It won't be married though. I don't know who it'll be. These are just some of the specialty ones we talked about that are breath activated. The RespiGuard is one that is specifically used for any medication that you don't want the gas to be, you don't want their exhaled aerosol to be vented to the atmosphere. We actually have a filter on it so that when they breathe in, they can only breathe in through the nebulizer, but when they breathe back out, it's got a one-way valve that it only can go out through that port and be filtered in the process. Okay. Next group are ultrasonic nebulizers. You don't see these in itself that much anymore, but they basically used what's called a piezoelectric crystal, and this crystal vibrates when electricity is applied to it. That vibration that is there allows for the medication to be nebulizers. So it's not the typical way we end up using with a jet nebulizer where it draws up the medication. This is a totally different principle, but the nebulization occurs secondary to the vibrations. If anybody's had their jewelry cleaned, they probably use an ultrasonic nebulizer or an ultrasonic cleaner to be able to do it, and just basically taking those principles and applying it. The particle size that is generated is proportional to the frequency, so the faster that thing vibrates, the smaller the particles become. And the amplitude affects how much actual output occurs. What we end up having is really the medication placed into what's called a couplet. It's a little cup that sits above the ultrasonic nebulizer. So here's my crystal that's vibrating. My medication is in this little medication cup. These vibration, these ultrasonic waves that are created, bombard against the medication cup, which then creates the nebulization. So it's kind of a backwards way of end up doing it. You can see that it has baffles there, so you end up having larger particles falling back into the medication cup. An example, probably where you'll come up more is something very similar, but it's called a vibrating mesh nebulizer. And the Aeroneb is the brand name for this. This is one that you will encounter, especially on mechanically ventilated patients. It's a very effective nebulizer in the clinical realm, but it basically has a small mesh screen that again vibrates. And that vibration is what causes the medication to be placed into an aerosol form, which is then inhaled. It could be done with a mouthpiece, as shown here. It can be placed in line on the ventilator circuit and delivered. What the heck is these red things on there? My God, must have been scribbling on something. And again, this is the Aeroneb is the example. Notice the particle size is very, very effective. It's right in the desired range we want for deposition into the small, medium-sized airways, and most drugs can be nebulized with it quite effectively. And this is just another example of another brand, the PeriFlow, that has, again, that vibrating mesh technology. And they're so cool that a kid can, even with a battery pack, go take a breathing treatment while he's getting ready to play baseball. This is a brand new one. It is not pending FDA approval. It has FDA approval. There's no propellant. And there is basically a few medications that we'll end up seeing that are utilized with this. For right now, just recognize that there's an alternative way for specific medications to be nebulized. It's called a RSPT, and we'll talk more about it when we talk about specific bronchodilators. Okay, let's talk about these last bits here. First of all, Jamie's favorite, the SPAG. Called a small particle aerosol generator. It was manufactured for the delivery of one specific drug. The drug is Virazole or ribavirin. It used to be used for bronchiolitis secondary to RSV infections. So bronchiolitis meaning inflammation of the small bronchioles. Respiratory syncytial virus is the virus involved in most kids who have RSV. This is RSV season. From November through probably March, very, very common for small children to end up getting RSV infections. RSV infections cause severe bronchiolitis to the point that they could require intubation and mechanical ventilation. So the SPAG was the drug ribavirin was nebulized. There are very few indications for it in bronchiolitis now. It's not part of the standardized treatment, which is good. It is, though, utilized for patients who are immunocompromised. So if you're working in a heart transplant area or a lung transplant area, they might be on Virazole, and the SPAG generator may be used. That's all I want you to know about it. Okay, this is what it looks like. Woot woot. It's got 2 flow meters, one to cause nebulization, one to create a drying chamber. It's a pain in the neck. If anybody's ever worked with one, cleaning them is a pain. So there we go. I don't care that you need to know this. Don't need to know this. Good. Done? SPAG. Sorry, what could be more involved for you, Jamie, but that's the way it is. Now, there are some times where we need to deliver medication over a longer period of time. So the protocol for a lot of asthmatics coming into the ER is that we'll do back-to-back-to-back treatments. Give them a treatment. When that's over, give them another treatment. When that's over, give them another treatment. Alternatively, we could do continuous. So I could give a therapy, instead of delivering 2.5 milligrams of albuterol, I can deliver 15 or 20 milligrams of albuterol over 2-3 hours. And the effectiveness of that is a little bit better than having that peak and valley that you end up seeing from successive ones. These nebulizers have to have a larger volume. The typical nebulizer that we would use, the garden variety one, doesn't hold enough solution to be able to nebulize for that long of a time. And if you'll notice, they're all the high output, extended aerosol, respiratory therapy, or heart nebulizer. Ooh, I gotta find something. I don't know why the O is in there. Heart. But they're called heart nebulizers, okay? And I don't want you to know the difference between them. Just recognize that heart nebulizers means large volume, okay? And even though we're putting longer in there, the concentration of the drug doesn't change. There's what they look like. Kind of nice. I don't know why I have this slide on here, but plenty of room for all of God's creatures right next to the mashed potatoes. Absolutely. So, one of the things that you will encounter is the calculation to go through and determine how much medication I need to place into the nebulizer and how much diluent I need to add to be able to get the duration involved. This is a little bit cumbersome, so let me work through it, give you an example. There's some examples on my website, but you will encounter one of these on the test. Okay? So, physician's order says go ahead and deliver 10 milligrams per hour of albuterol. Albuterol, as we know, is 0.5% solution, which means there's 5 milligrams per ml. That's a given. You should know that. The nebulizer output, in other words, what the nebulizer is able to accomplish, is 5 milliliters over 10 minutes, or roughly 30 milliliters per hour. And the duration of therapy should be for 8 hours. Kind of an extended therapy there, but you get the idea. So doc wants 10 milligrams per hour for 8 hours. I got a 0.5% solution in a nebulizer that can generate 30 milliliters per hour of nebulization. We need to calculate how much medication and how much diluent needs to be added or placed together into the nebulizer. So let's go through the steps. First step, how much drug will be delivered? It's the dosage desired times the duration. Second step, we're going to go ahead and figure out what the total volume would be, and that's the output of the nebulizer times the duration. Third step, how much drug? It's a drug concentration in milligrams. And then figuring out your diluent is how much total volume there is in that duration of time minus the drug volume. So let's go through these step by step. This slide probably makes more sense than those other goofy words. Step one, how much drug is needed? Well, he said he wants 10 milligrams per hour, and the duration of therapy is 8 hours. So I need 80 milligrams. Okay. The total volume that we're going to generate, well, the nebulizer is 30 milliliters per hour. Duration of therapy is 8 hours. So that means I need 240 milliliters. Step three, how much drug do I have? Well, I know that my 0.5% solution means there's 5 milligrams per milliliter. You can do the math on that if you don't believe me. Okay, 0.5 grams and 100 milliliters, you get it. Okay, 5 milligrams per milliliter. I want to have 80 milligrams delivered, so how many milliliters is that? Set it up as a ratio. Doing the math, cross-multiplying, 80 milligrams is equal to 5 milligrams times some unknown. 80 divided by 5 means I must have 16 milliliters of that medication. Don't cry yet, Katie. There's lots of time for it. Okay. So 16 milliliters has to, I need to draw up 16 milliliters of that 0.5% solution and put it into the nebulizer cup. Now I need to figure out how much diluent I need to put in there. Well, if I needed 240 milliliters, and I have 16 milliliters of diluent, that means I have to put 224 milliliters of saline into that nebulizer also. This will allow me to deliver 10 milligrams per hour for 8 hours, given that my nebulizer has 30 milliliters per hour of output. Oh, dear God in heaven. It's hard to do that. It's hard to show it when you're not using real fractions. So that's the same thing as saying which is the same thing as saying X milliliters is equal to 80 milligrams. Milliliters, 5 milligrams. Milligrams goes away, 5 divided by 16 milliliters. Set it up as a ratio. This goes back to what we were doing in 1060. Right? Okay. Now, there are a couple of practice problems on the website. I suggest you go there, and I have the problem and the answers to them there. Okay. How do I know if my therapy works? If I'm giving a treatment to an asthmatic, one of the things I want to do is I want to monitor the response. Well, one of the things we typically use, especially in the home, is peak flows. It's a very inexpensive, disposable device. I mean, it's reusable. You throw them away eventually. But I can measure the inspiratory flow rate, and more importantly, the expiratory flow rate. Normal inspiratory flow is somewhere about 30 to 35 liters per minute. Not that you need to know that. We can measure this in the PF lab. We can measure this at the bedside. We typically have, like I said, devices that the patient can end up taking home. Asthmatics, this is how we judge their improvement, is looking at peak flow. Having the patient forcefully exhale through the device to be able to measure what the peak expiratory flow rate is. We instruct them to take a deep breath in as deep as they can and blast it out as hard and as fast as they can. It's usually measured in liters per minute, although in the PF lab it's measured in liters per second. Not that that matters. But what we're going to do with our asthmatics, Ginny hasn't got to asthma, right? Okay, when she does, she'll go back through this. We're going to use what is called the personal best. Now, based upon height, gender, and age, I can look on a magical table and come up with what the peak flow should be for that person. But better yet, why not use them as their own control? Yeah, so what we're going to end up doing is just over the period of a few weeks, when they're healthy, when they're not in an asthmatic crisis, I'm going to monitor their peak flow. And we're going to use what we call the traffic light system to determine severity. Did Mary talk about that? Why am I bothering? I should just go home. It's an upside down traffic light. We want the patient to be in the green zone. Green zone is 80 to 100% of their personal best. Yellow is 50 to 80. I don't know if she gives a different number. Something in my mind says it's a different number that she had, but. And then red zone would be less than 50. Yellow zone means you're in trouble. You need to increase your medication. You need to reevaluate the situation. Red zone means you need to get to the hospital. Okay, and this is the way we want to instruct our patients to be able to manage their own asthma. So let's say my personal best was 400. 80% of that is 320. So as long as I'm above 320, I'm doing good. Yellow zone is somewhere between 200 and 320, and that's basically the area that there's something going on, and we need to perhaps add a different medication, perhaps do something else in the process. And then below 200 is the red zone, and that's where we need to get to an emergency location. Okay. So 80 to 100, 50 to 80, less than 50. Shut up. This is where you can use a linear regression equation to actually determine it. Not a chance in the world. Peak flows have variances and normals depending upon body size. You don't need to know the normal values there.
Wait, the screaming flag?
You didn't need to know that either, that's right. Most people would say when your peak flow gets below 200, you're starting to get mild to moderate, but again, that depends upon the personal best. If I'm talking about an 8-year-old versus a 38-year-old, two different numbers there. So that's why these numbers are fluid. But you can see that as you get lower and lower, we can classify it as mild to moderate, moderate to severe, severe, very severe. We can use peak flow instead of the FEV1. We've gone through this top one before. Peak flow, because I'm not really measuring the volume, it's not 12% and 200, it's usually about 15% improvement is considered a significant improvement in bronchodilators. I like using FEV1. I think it's just much better. This just goes through the calculation because it's not 200 milliliters, it's not significant. Here's one that is showing a significant improvement. All right, how fitting is that one? Let's take 5, and we come back. We'll start on Module D. Hold on. This is probably the most important module of this course, so you might want to pay attention or not. This will be on the test, yes. And as we'll go through, some of those drugs that you have memorized will make a little more sense perhaps now, or not. I believe it's chapter 5 in Colbert, and there's a pretty extensive stuff in that Evil Egan also. We know about the drug cards, I'm not going to worry about that. How sad. This is wrong. Oh, the video.
Okay. Everyone's getting ready for a party right now. She just got out of the shower. Oh, baby powder. Yeah. That thing's full of it. Should be a good show.
You like Bob Marley.
Not only did he record it, he put it on YouTube. All right. This is Traverse City, so it's local.
Another dangerous game kids play is to tunnel in snowbanks near the road. A few years ago, one boy
Only in Michigan. All right, let me sure I get this on here. Okay, we're rolling. So just kind of remembering back to our conducting airways. This goes back to 1050, probably module A, way long time ago. We know that there's 3 different levels that are there. A mucosal level that has those ciliated cells that propel mucus up. It's primarily as a cleansing mechanism. There's a submucosal where they have the bronchial glands and the smooth muscle and capillary networks and elastic tissue. And then there's the adventitia, which is a connective tissue that the airway is supported upon. So here we can end up seeing our submucosal level with the goblet, with the bronchial glands. Goblet cells are located in the epithelial layer, that mucosal layer on the top, or the innermost. And then there's also within that submucosal, there's the smooth muscle and the capillary network that is there. As we go down, there's less and less cartilage. You get down to beyond the 5th generation, we start having bronchioles being present. And then we end up having that musculature not being so much sheets as just being strands. So when that muscle constricts, the caliber of the airway significantly changes. And this is just a picture of you can see the smooth muscle being less and less prominent as you get further and further down. All right, the term bronchoconstriction means a narrowing of that airway caliber. There are 3 primary reasons why that occurs. The first one is the spasm of that smooth muscle that is surrounding the bronchiole. So as that muscle constricts, it causes the airway to become narrowed and bronchoconstriction occurs. Bronchoconstriction can also occur secondary to edema, a swelling of the airway itself because that mucosal layer now becomes inflamed. The third reason is that the caliber of the airway narrows because of the accumulation of excessive amounts of secretions. When G goes through asthma, the pathophysiology, it's all three of those together. There's a bronchospasm that happens, the smooth muscle becomes stimulated, the airway edema occurs, and secretions are, your bronchial glands and your goblet cells increase their mucus production. All of them lead to an increase in airway resistance, increased work of breathing, and the sensation of dyspnea expressed by the patient. Okay, just want to make sure we're clear on distinction between bronchoconstriction and bronchospasm. Spasm makes up constriction, but constriction also has more there. We know about our sympathetic and parasympathetic system. We know that there is a balance that is present, and when the balance gets out of balance, you end up having either bronchoconstriction or what we're going to strive for is bronchodilation. But it's a balance between those two systems, the parasympathetic and the sympathetic. We know the sympathetic system has acetylcholine and norepinephrine as neurotransmitters. The parasympathetic has the nicotinic acetylcholine and the muscarinic acetylcholine they both act on the smooth muscle. And you've seen this chart before as far as the various things that can end up happening as you have sympathomimetic or sympatholytic, parasympatholytic, or parasympathomimetic. God, those words are long. Okay. What we're going to strive to do is have bronchodilation. And there's two primary ways we can accomplish that. Either by having an increase in sympathomimetic stimulation or a reduction in the cholinergic parasympathetic stimulation. Okay? So I can either block the parasympathetic system, bronchodilation, or I can stimulate the sympathetic system, bronchodilation. Okay? They both are ways to get there. And we'll find out in a second what this CAMP, CMGP, MOUSE means. We're going to call these three, I give them the name, I don't know, pretty common, but front door, back door, side door. Front door are your beta 2 stimulators. These are your adrenergic or sympathomimetic bronchodilators, and they work by increasing what is called cyclic AMP. Technically cyclic 3', 5' AMP, but cyclic AMP. Okay. Drugs that inhibit the other end of that scale, cyclic GMP, are called anticholinergic or antimuscarinic or parasympatholytic bronchodilators. These are the back door. These are accomplishing the same event but through a different pathway. Then there's the real there's another group of drugs which we're not entirely sure how they work. We have a general idea, but they're called side door. And there are a group of drugs called the xanthines, of which theophylline is probably the most common one we end up encountering. So let's talk about the beta 2 stimulation, the adrenergic stimulation. The first group of drugs we'll talk about are called catecholamines. Now in your back, this is blown up for you. This is going to be your friend. It looks ugly. We're going to break it down into little chunks. Now notice on the bottom what you have is bronchodilation or bronchoconstriction. The cause of the bronchodilation is an increase in this thing called cyclic AMP. Okay. Stimulate that production, bronchodilation happens. If I have, on the other side, I have an increase in cyclic GMP, and that causes bronchoconstriction. So it's the balance between those two as to how much the airway is enlarged or constricted. Okay. Okay. We're going to take a look at this left-hand side first. This is how our beta-2 adrenergic works, our beta agonists. You'll notice the first top spot up there is I have a beta-2 receptor. It's keyed to specific drugs that when this is stimulated, the second step, okay, so first step is stimulation with the medication. Second step is I have the creation of a substance called adenyl cyclase. Adenyl cyclase, A-D-E-N-Y-L cyclase. It's an enzyme. That enzyme causes cyclic AMP to be created. Cyclic AMP, when it is increased in its concentration, leads to bronchodilation. Woot, woot, woot. If you don't like that one, these are the steps I just mentioned. How about this one? I have a drug that's a beta agonist. It stimulates a beta receptor. Adenyl cyclase is formed, which converts ATP into cyclic AMP. Cyclic AMP goes ahead and creates dilation. These are how our bronchodilators work. All right, let's go ahead and, well, that's a simplified version. This is out of respiratory care a few years back, and we're just talking about how this process really works, and I don't even want to go there. But we'll find that that conversion of ATP to cyclic AMP through the presence of adenyl cyclase is the nuts and bolts of it all. And the way the stimulation occurs is it actually goes in and out, but we don't want to go there. Okay. The process of creating bronchodilation is not something entirely new. There was a substance called ma huang, which was a Chinese herb that the Chinese recognized had the ability of relieving an asthmatic attack and causing relief. Early in the 1900s, we knew that there was this substance called adrenaline inside the bloodstream. We then said, hey, why don't we manufacture that or use that to fight bronchospasm, specifically used as a subcutaneous injection, although it first was used as an aerosol back in the early 20th century. Little guy had real bad asthma, couldn't go outside and play, until he became president. It's Teddy Roosevelt. He was a horrendous asthmatic. He used epinephrine as one mechanism to do it. But the group of bronchodilators known as catecholamines are those which have epinephrine as its building block. Okay, so that's kind of the gold standard for catecholamines is epinephrine. Everything else is built upon it. Now, don't get too freaked out in organic chemistry. Some of you probably took organic chemistry and think it's great. You never have, so can't comment. But basically what it is it's what's called a benzene ring. It's a ring of hydrocarbons, carbon and hydrogen and oxygen in mixtures, that has two hydroxyl groups. That's what the OH is, HO in this case. And they're at the position of 3 and 4 on the benzene ring. Don't need to know that specifically, but that's one component. I got a benzene ring with these two hydroxyl groups that are attached. There's also a side chain, a bunch of other stuff that's attached to it, a tail. Change the position of those OH on the benzene ring, I change duration. That's the way we create drugs that last longer, is I change the position on the benzene ring. Change the side chain. Changes to that allows for more specific beta-2 sensitivity. What I ideally want is a drug that only stimulates the beta-2 receptors, not the beta-1. What's beta-1 again? Heart rate, force of contraction, right? I don't want my heart to beat faster. All I want is I want to bronchodilate. So the more beta-2 specificity we can have, the better off it is. Those are changes to this amine side chain. Changes to the catechol nucleus, the benzene ring, change the duration of the medication. And over the past 5-6 years, we have seen a proliferation of drugs coming onto the market, which makes my life miserable, because now I have to include them in the course. But what they end up doing is, instead of being a drug that we're giving every 4 hours, we're now giving once a day. Whole lot more compliance when you take a drug once a day than if you take them every 4 hours. Okay? So a benzene ring with these hydroxyl groups is duration. The amine side chain, the tail, has to do with beta specificity. Might be an important slide to remember. Just saying. This is the catecholamine structure. This is off of Colbert's site. So all I have is there are these the carbons. Now I have the catechol nucleus on the left, the side chain on the right. And that's it. Okay? If you're interested, you can go on Colbert's site, and they have that picture. I just clicked on it again. Okay. So again, these drugs mimic epinephrine. And epinephrine has the ability to stimulate all three. So epinephrine not only is beta-1, beta-2, it's also alpha. These were drugs, these are our first creation of a bronchodilator. Something that was mimicking epinephrine or epinephrine itself. Fast-acting, life and death situations that work. Okay? The oldest group are these things called catecholamines that are built on epinephrine. Resorcinols, saliginins, and newer ones are newer generations of bronchodilators. Okay, so as we've gone on in time, we've created new subclasses. Just like antibiotics, we'll find that there's multiple generations of antibiotics. Each time they make a new generation, they get more effective. Same idea here. So here's our catecholamine base. We end up having epinephrine and a drug, isoproterenol, isoprel, not used anymore, but just kind of as a building block. This was the drug we ended up using. Catechol nucleus, amine side chain. Okay. We talked about that. These drugs are destroyed by COMT and MAO. Those substances, remember those how catecholamines, the norepinephrine, epinephrine is broken down to the neuromuscular junction. They're present also in the stomach, so I can't give these drugs orally. They break down. They have very bad, a high tendency for tolerance in the development of tachyphylaxis. Tachyphylaxis, if you remember, is a rapid onset of a deterioration of the drug not working. Tolerance means you need more and more of the drug to be able to get the same effect. Good news, rapid onset. Within minutes, you end up having relief, but a short duration. Okay, and they're inactivated by light. So if you ever see most drugs that fall into the category of a beta agonist, if it's a liquid, it's in a brown bottle. So light doesn't affect it. Oh. And what they end up creating is something called adrenochromes. You don't need to know that, but when I was playing Sputable, that was our team name. We were the adrenochromes. You know about those two terms. Some of the representative catecholamines, epinephrine or adrenaline. One drug that we will be utilizing frequently is a cousin of epinephrine called racemic epinephrine. Epinephrine also, there's a derivative norepinephrine that is used to manage blood pressure, as is dopamine. Those are all considered catecholamines, and they all will basically have the same effect. The latter two you don't need to know right now. You'll come across them when you get into the ICU. So, epinephrine. I believe Primatene Mist has finally been pulled off the market. I should probably go into the pharmacy and take a peek. Who has a spouse that's a pharmacist? Monique, can you ask him that? If Primatene Mist is gone? You're going to text him? Okay. There you go. It's a nasty drug. You have huge tolerance to it. You build up tolerance to it, so you need more and more of it. And it's stimulating everything. It's epinephrine. It's going to stimulate your heart rate to go through the roof. And patients swear by it. It's awful. Can be given subcutaneously. We actually use it as a direct installation where we squirt it down during a bronchoscopy because of a pulmonary hemorrhage. See this bullet point here? Pay attention to it. The second bullet point, treatment of pulmonary hemorrhage during bronchoscopies. Doc's doing a bronch, puts a little forceps down there to get a sample of a potential tumor, some tumorous tissue, and when he yanks on it, pulls it off, the patient starts bleeding. And the only way to stop the bleeding is with epinephrine. It's also, as you know, used for anaphylactic reactions, bee stings. Somebody's allergic to bee stings and they get stung by a bee, you want to have an EpiPen handy. And we know that it stimulates all three, alpha, beta 1, beta 2. Some other stuff, it may contain sulfates, which is kind of, sulfates can trigger an asthmatic attack, so why would I want to have a drug that has sulfites in them? Notice the rapid onset. You don't need to know the actual times. I'm not going to ask you, is it 3 minutes or 4 minutes? Peak effect within 5 to 20 minutes and very short duration though. Doesn't last. Lots of adverse reactions to them. Okay, this is really true of all bronchodilators, all beta agonists, all have that same kind of side effects. Yeah. It's off? Good. There you go. You don't need to know the dosage for this because we're not going to administer it. So don't even worry that much about the fact that we're going to nebulize it because we're not going to. There's a whole bunch of other drugs that were out there that we used to use. This is for the old people. When I came onto the market, this was the most common drug used, Bronchosol. Everybody got Bronchosol. It was cool. You got wheezing, I'm giving you Bronchosol, baby. And eventually better drugs came out, so they got replaced. Let's talk about racemic epinephrine because this is one you do need to know. Racemic epinephrine is a form of epinephrine. It's a synthetic form of it. And it's a mirror image. We talked about these things called isomers or racemates. They're basically mirrored images of the drug. So racemic epinephrine is similar to epinephrine in structure, but it's not as potent. It doesn't have the same amount of strength. We don't really even use it as a bronchodilator. What we use it for is its vasoconstricting function. Alpha agents vasoconstrict, right? So if I have somebody who has a lot of swelling in their upper airway, I'm going to use this as a mechanism to reduce that swelling. So patients with croup, patients with something called epiglottitis. Jeannie hasn't covered those yet. Patient who has stridor after the endotracheal tube is removed. We give them a treatment with racemic epinephrine. Okay, that vasoconstriction will cause the swelling to be reduced. So again, as a review, catecholamines have these benzene rings with an amine side chain. There's sympathomimetics. We have changes to the structure and lengthening of the chain to have increased duration and to have more beta 2 specificity. And we end up having that bronchodilation beam. Good so far? Those are my catecholamines. Those are kind of the base ones. Those are the ones we lived and died by. Long gone. Forget about it. Second group were something called resorcinols. Resorcinols have notice the position of that hydroxyl group. They moved them. In doing so, you move them, you increase duration. So these drugs typically, these group of drugs, typically have a longer duration. The other thing that occurs, because they're not catecholamines in the true sense, they don't have the problem of being broken down by COMT and MAO. So I can give them orally. They can go through the GI tract and not be broken down. Good news, they last longer. Woohoo! Two primary examples, metaproterenol and terbutaline. Let's see what these guys look like. So they have the position of the hydroxyl nucleus moved to now a resorcinol, and they end up having better beta-2 specificity with longer duration. Everything you would want in a drug. This is a drug you don't need to know, because I think it's going to be gone real soon. It's a drug that is available for aerosol solution inhalation. The MDI has already gone away, so I got a feeling you're not going to see it that long. It is still manufactured, though. It's also available as a tablet or a syrup. So small children can just take some metaproterenol, better known as Alupent, syrup, and get the reaction from there. Very slow onset, but a nice long duration. That's the good news. And again, I can't see this drug being around very much longer. There's better drugs on the market. Why continue to produce it? Terbutaline is a little bit different. And what I want you to know about terbutaline is that second major bullet point. We don't typically use it as a bronchodilator for asthmatic attacks. Where we do use it is to inhibit labor contractions in a woman who is having active labor too early. Okay. There are some weirdness between the uterus and the lungs. Yeah, there is. Okay. If it's going to be done as a nebulization, and it wouldn't be in the case of the labor, but if we are using it as a bronchodilator, that would be considered as an off-label use because it's not approved for that. It can, however, be given subcutaneous. Like epinephrine can be given subcutaneous, so can terbutaline. Has a little bit less side effects than the epi does. Third generation. Thank God, we got someplace now where we can use drugs. These are the siliginins. Siliginins. Notice what ended up happening is not only did I move that hydroxyl group, but I also changed it from an OH to something totally different. So that changes it from a resorcinol to a siliginin. Again, they're not metabolized by COMT, and they're very beta-2 specific. And there's many examples to them. So let's talk about some of them. And this is just a little video it shows on the... I'm changing the resorcinol nucleus to a siliginin nucleus. First one, our old buddy. Good question, Mel?
Yeah, are you going to ask like what position of the bed?
Nah. But you should know that changes in position do cause a change in duration. That I will expect you to know.
Okay.
We're not chemists. So albuterol, better known as Proventil or Ventolin, or as we call it, albuterol or Preventol, because it's given for anything. It is the most common beta-2 agonist used on the market. Rapid onset, long duration, just what you would want to have. Multiple ways that we can administer it. Again, we're going to look primarily at the solution that being nebulized in the MDI. It's also used in premature labor. It's also used with hyperkalemia. And one of the funny ones that you may end up hearing is it's used for something called proctalgia fugax. Which is what? It's where the anal sphincter spasms and you get just horrible pain. So what do we do for it? All better off. It's literally the case. Yep. And it's not given rectally, in case you're wondering. It's given inhalationally. Okay. There is a subset of this Aeroneb which is available as a pediatric dosing. So that's our primary one that we're going to encounter. You guys should know the dosage for this and all the stuff involved. Second one is a drug called Previously Maxair. This is that weird one that uses the breath-activated meter-dose inhaler, the BAI. It's supposed to come off the market, but last time I checked, it's still out there. The problem is that inhaler still uses CFCs, and I don't believe the manufacturer wanted to go through the trouble to get it to convert to HFAs. So just know Previously Maxair and be done with it. This is one that you should know also. The drug is called salmeterol or Ceravent. Has kind of a unique principle that it has the ability to dissolve into lipids or fats. So in doing so, it can hang around for a lot longer time. And what ends up happening, remember that little chain that I showed you? It comes back and it stimulates it, and it stimulates. And it's like a little kid poking you. But each time it does it, it re-stimulates that beta adrenergic receptor. It's very slow onset, not to be used in an acute attack. They actually have what they call a black box warning, where on the packaging is a big black box that says, "Do not use for acute attacks." So what did people do? Use them for an acute attack and got nothing and died. Well, it's not a good idea, perhaps. This is what we're going to call a maintenance drugs. Albuterol, Previously, those are relief or rescue medications. These are long-term maintenance drugs. Ceravent can be by itself, or it can be in combination with a corticosteroid. That's where Advair comes in. And it's because it has nice long duration, twice a day. Okay. Maintenance drug. Did I mention that? Maintenance drug. Very important. So look at that chain. Yahoo! It's way out there. It's not the longest acting one, though. We confuse you? A little bit longer. Okay, we talked about isomers before. We talked about these racemates. Okay. An example here is the albuterol armature. You have a right chain and a left chain. Notice the right chain has different functions than the left side. So what the guy did is says, you know what, let's get rid of that left-hand side. Let's just focus on the right-hand side because that's the business side. And they created a drug called levalbuterol. Levalbuterol is a cousin to albuterol. It's an isomer, but it has more potency in theory with less side effects in theory. It's available as a solution for nebulization. It's available as an HFA MDI. Short onset, long duration. In theory, it should be able to be dosed less frequently. But I will tell you, we used to give Bronchosol every 4 hours. When albuterol came on the market, every 4 hours. When levalbuterol came on the market, every 4 hours. It's like, dude, you got a drug that lasts longer. Why are we using higher doses? Finding an uphill battle. So there you end up having Xopenex. is the brand name. Okay. So it can get by with an effective dose of 0.63 milligrams compared to how much albuterol? Isn't a half a milliliter of a 0.5% solution? 2.5 milligrams. So it's far more potent. Now we come to my favorite drug, formoterol. I think this is a great drug. It's a maintenance drug. However, it does have a rapid onset. You start seeing reactions within 15 minutes, but it lasts 12 hours. I like this drug. It's classified again as a maintenance drug, which means we do not use it in an acute attack. It can be given as a dry powder inhaler every 12 hours. And the drug that you'll see this is Floridil and Proformis. A cousin to it, again a mirror image of formoterol, is arformoterol, better known as Brovana. And this is again a long-acting beta agonist. We're going to call these drugs, these maintenance drugs in this category, LABAs. Not a SABA, a slow-acting beta agonist, or short-acting, beta agonist, but a LABA. Albuterol, perbuterol, those are SABAs. Formoterol, arformoterol, Serovent, these are all considered LABAs. Okay. And I believe formoterol and arformoterol are on the next 8 drugs that you'll need to know. Serovent is 2. They were in the last one? Okay. A new one. I'll get it. Indicaterol, or better known as Arcapta. Do you have the slide? Okay. Again, longer and longer and longer durations, to the point that this can end up being given once a day. I'm liking this. I get bronchodilation that lasts all day long. Okay. It uses a specific device called a neohaler, and again, it's dry powder, so it needs a very high peak flow to be able to be utilized. I gave you if you want to type that in, you can go ahead and go to the website. I don't think it's going to happen. But again, you have little blister packs. The capsule's placed inside, which of course is always a problem because patients want to take the capsule orally. We then go ahead and close it, push the button, punctures it, and then we can then inhale it. Brand new one. Something called Volanterol. Available as Breo-Ellipta, available as Anoro-Ellipta. What I want you to know about it, that it's a long-acting agent, once a day. The case of the first one, it's combined with a corticosteroid. In the case of the second one, it's in combination with a anti-cholinergic agent. Have you seen this yet?
I think I heard like one patient talking about it.
Yeah, it's relatively new. It's like last year it came out onto the market, and it's been in Europe for a long time, but it's just made it onto ours. And this is the big push: is to have a LABA combined with a steroid, or a LABA combined with a anticholinergic agent, both of which act for long periods of time. This is the one that Respimat nebulizer I talked about. This is where it's used also. I have not seen this, so I won't ask any questions on it, but recognize that the reason why I'm giving you these is these are medications your patient probably are on at home. We'll never see them used in the hospital because they're in an acute exacerbation. They need something more than this maintenance drug. But when you're going through their medical record and you're looking at the medications they're on at home, if you see Straverti, Respimat, you'll know where it's coming from. And I just throw these out there because every year when I go back and I update my my list of medications, I see who's on the horizons And these last few drugs I talked about, they were on this list of experimental drugs 2 years ago. So every couple of years, there's new ones that come out. Look at this patch. How cool is that? No inhalation needed. Just a patch on you. Woohoo! And then there's this one, PF06 0061035. Where do they come up with these ones? I don't know. Okay. So we're going to classify these drugs like metaproterenol, like albuterol, like levobuterol, like perbuterol. All are rescue agents. All the rest of them. And you notice your book doesn't even have half of the ones I just talked about. It's too new. But those are considered long-acting maintenance drugs. When we come across talking about asthma and COPD, when Ginny talks about the medications utilized for them, we're going to separate those two out. Okay? It's important to teach the patients that. So there we have our other long-acting. There's a bunch more on there. I got to add to that list. Okay. So again, SABA's for rescue, LABA's for maintenance. We talked about the black box warning. The only two drugs that we may use for continuous nebulization, we talked about albuterol earlier. And there is, I mean, this is not anything to necessarily be just willy-nilly about. You can create tachycardia. You can create hypokalemia. So one of the side effects of continuous nebulization of albuterol is the potassium level falls. So you need to be cautious when looking at that. For as a general rule of all sympathomimetics, when you talk about side effects, you talk about bad things that happen or maybe indesirable things that happen, these are pretty much standard for all of them. So when I say that you have to memorize on your drug card the side effects, they're all the same. Common sense things. Some more side effects that are there. Urticaria. I always wonder what that was. I always thought of urticaria. Hives. Hanseníase for hives. Let's stop there. I was going to do 2 more slides, but we're good.